Hello, welcome to APP to APP virtual lectures. We have two viewer audiences this evening, my Catholic doctor and APP to APP. My name is Martine Altieri. I've been a PA for about 14 years now, and my expertise is in hospital medicine, cardiology, and cardiometabolic health. And I work in Boca Raton, Florida. I run an obesity medicine clinic in a cardiology setting. Tonight, we are going to discuss obesity as a disease, and I say that it's a disease of abnormal physiology, and we are going to loop in the GLP-1 receptor agonists, which are the new molecules on the block that are very popular, and so we can understand their role in obesity and why they have been so successful in weight management. I do not have any relevant financial disclosures. This lecture is for educational purposes only. We are not giving you information on how to treat your individual patients. These are my learning objectives. After this lecture, I anticipate that you will recognize why obesity is a disease and understand the different definitions of obesity. We are going to identify the pathophysiological mechanisms that contribute to obesity and associated comorbid conditions and complications. We are going to try to understand the role of adipose tissue in inflammation, dysfunction, and its role in obesity, and also identify adiposity-related diseases. We hope to understand also how peripheral and central signals controlling energy intake and the role of gut hormones, particularly GLP-1, to better understand those novel therapies. Understand also the science behind metabolic adaptation and why this makes weight loss so difficult to maintain. These are the contents of the lecture. We are going to start with definition and classifications. We are going to look at the prevalence of obesity in the United States and see what are the multifactorial causes. We will dive into pathophysiology in detail and learn about adipose tissue and all that. Adipose tissue dysfunction. We are going to learn also about the peripheral and central signals that control energy intake. We will learn about the role of sleep and stress in obesity, what is metabolic adaptation, and at the end, I will leave you with my conclusions and key takeaways. What is obesity? According to the CDC, obesity is defined as a body mass index of 30 or higher, and overweight is defined by a BMI of 25 to 29.9. And according to the Obesity Medicine Association, obesity is a chronic, progressive, relapsing, but treatable, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass and physical forces resulting in adverse metabolic, biomechanical, and psychological health consequences. This is another definition. Again, more experts are weighing in, and this is according to the American Association of Clinical Endocrinologists. And again, they define obesity as well as a complex multifactorial condition. And the common theme here is it is a disease. We will look at some classifications. So this is the World Health Organization classification. And this is based on BMI. What is BMI? We hear all the time body mass index. It is not a percentage of body fat. It is only part of a diagnosis of obesity. The BMI, a little history behind it, was first calculated in the 1830s. So this has been around for quite centuries and became the standard for categorizing obesity in the 1980s. Today, many clinicians find its simplicity outdated and flawed. It doesn't take into consideration, for example, age, gender, race, muscle mass, or fat mass. Someone who works out a lot at the gym and build up a lot of muscle mass, they will have an elevated BMI. And we cannot say that these people are obese, but then again, this is the only measurement that we have, and we are unfortunately basically forced to use in clinical practice. So according to the World Health Organization classification, a patient is said to be overweight when they have a BMI between 25 and 29.9. We avoid using derogatory terms like severe obesity or morbid obesity, we will say that now we divide them by classes. We have class 1 obesity. It's a BMI of 30 to 34.9. Class 2 obesity, it's a BMI of 35 to 39.9. And class 3 is a BMI of over 40 or more. There is a different classification based on BMI still, but with different nomenclature, if you want. Underweight, less than 18.5 with a BMI. Healthy weight is between 18.5 to 24.9. A patient is overweight when it's 25 to 29, obesity 30 to 39.9, and they call it severe obesity when it's more than 40. And this is according to the Obesity Action Coalition. So also, I want to go back to the previous slide. I want to mention how you notice here in Asian ethnicity, they have a different classification. Their numbers are a little bit lower. We have to take that into consideration when classifying Asian population based on their BMI. So having a BMI in the overweight range is also a health concern. That's why it's important to note that it can lead to other health problems, including obesity. Obesity is a disease where a person's weight is in the unhealthy range. That's the BMI between 30 and 39.9. And we say that someone is severely obese when they have a BMI, when they are more than 100 pounds over their healthy body weight. And that's when you have a BMI greater than 40. That's classified as severe obesity. This is a staging classification, and it is according to the Edmonton Obesity Staging System, which is a 5-point ordinal classification system that considers comorbidity and functional status in predicting mortality in a nationally representative US sample. Edmonton Obesity Staging System is not based on the degree of obesity according to BMI like we just saw, but on the absence or presence as well as the severity or comorbidities and also organ dysfunction. This figure shows us the 5 EOSS classification groups, which are based on the patient's medical, mental, and functional status. Current classifications of obesity are based on BMI, like we just saw, and waist circumference and other anthropometric measures. Although useful for population studies, they have important limitations, like I mentioned before, when applied to individuals in clinical practice. Thus, these measures do not provide on presence or extent of comorbidities or functional limitations that would guide decision-making in individuals. It is anticipated that the system, when used together with the present anthropometric classification, will provide a simple framework to aid decision-making in clinical practice. Now we are going to go over the prevalence of self-reported obesity. So according to the CDC, that's from 2021, overweight and obesity affects more than 70% of the US adult population, and it is estimated that 93 million Americans are affected by obesity specifically, and this is according to the Obesity Action Coalition. More than 9 million adolescents, children, and teens 6 to 19 years old are affected by excess weight, and children who are affected by obesity are 70% more likely to continue being affected into adulthood. So this is very serious. And we can see here on the chart, the areas in the United States that are the most affected. And we can, depending on which state that you practice, you can see what the prevalence is and how important it is to learn about pathophysiology of obesity so you can better treat those patients and, you know, provide the help that they need, because it is a serious, we call it, it is an epidemic. It is a serious problem in the United States and in the world actually, but our prevalence here is really high. What are some causes of obesity? It is multifactorial. We are going to go into details of all the factors that can play a role and lead to obesity. These are the multifactorial causes. We are going to learn about genetics and how genetics and epigenetics play a role. Hormones, I highlighted hormones because this is one of the major factors, and this is the one that we can actually act on. And this is also where the medications we are going to use in the treatment of obesity are going to be or going to be efficient. So we need to understand how those hormones play a role in obesity. There are also psychosocial factors. We have to know these because it's a holistic approach when we are going to treat a patient with obesity. There are environmental factors, socioeconomic, nutrition, lifestyle, sleep, and stress. There are some medications that are weight promoting. We are going to learn about those. We have a table that will kind of give us an overview of the most common medications that can contribute to weight gain. Other diseases also, PCOS, sleep apnea, Prader-Willi syndrome, insulin resistance, thyroid disease, and other genetic and neuroendocrine diseases also can promote weight gain. Genetically speaking, we see that obesity risk is polygenetic, meaning there's over 100 genetic variants associated with increased risk. Research studies on twins and families estimated that the heritability of obesity was at 40 to 70%. So a child with one parent with obesity has a threefold higher risk of being affected by obesity as an adult. So this is important when we see a family where the parents already have the disease of obesity. The same way we do prevention when we know a parent has coronary artery disease, hypertension, we have to be proactive with those kids. If the child has two parents with obesity, that risk is tenfold. So this is very serious. And one gene is the fat mass and obesity associated gene that's present in 43% of the population. The rare single gene mutations lead to severe obesity starting in the rare single gene mutations that lead to severe obesity starting in early childhood. The MC4R deficiency, leptin deficiency, and POMC deficiency. So what is the POMC? Individuals with the rare POMC deficiency, we're going to learn about these, leptin, POMC, and all that later on when we are going to talk about the regulation, appetite regulation, and all that in their role in weight management. So that the POMC deficiency completely lack the individual with the rare POMC deficiency, they completely lack the POMC system, meaning that these individuals have normal driven unopposed hunger, and they are typically severely obese at very young ages. Most commonly, obesity is polygenic, resulting from multiple genes, which can lead to increased hunger, reduced satiety, higher calorie intake, increased tendency to be sedentary, and increased tendency to store body fat. These are the epigenetic factors. Epigenetics is defined as the changes in gene expressions or phenotype without changing in DNA sequence. These changes in gene expression are due to environmental experiences and can go as far back as in utero and childhood. Environmental influences such as lifestyle, like nutrition, physical activity, alcohol intake, sleep, there's also the gut microbiomes, drugs, obesogenic toxins, and intrauterine environment are all factors that can change gene expression without changing DNA gene sequences. This can be passed on to other generations. Prenatal, postnatal, and intrauterine changes like maternal smoking habits, maternal weight gain, and blood sugar levels during pregnancy, they all contribute to offspring with increased obesity risk. Usually, babies from mothers who had gestational diabetes, they tend to be bigger babies. Actually, they tend to be born with 9-10 pounds, and these kids later on in adulthood, they are at risk of having the disease of obesity. The genes affected by environmental epigenetic factors, this is a very busy slide here, but in sum, what is this telling us is that genes are affected by environmental factors through epigenetic mechanisms. And genes that are color-coded, the genes are color-coded by mechanism. The genes within each section are specific for each factor, and genes placed in the middle space are common between at least two factors. So that's what this slide here is showing us, and we can see how they can all affect obesity. But thankfully, these are not common and pretty rare. We are going over psychosocial factors now contributing to obesity. Sociodemographic factors like gender, we see that women are more affected than men, age, ethnicity, race, and culture. Educational attainment, like high school education or less, depending on the level of education, we see people are negatively affected. Mental illness and substance use disorders like depression, anxiety, and eating disorders like anorexia, bulimia, binge eating disorder, and night eating disorder. Adverse childhood experiences, a kid who experienced sexual, physical abuse and neglect are at higher risk of having obesity in adulthood. 50% of people with severe obesity reported some sort of emotional neglect during childhood. Environmental factors, again, we have nutrition behaviors, physical activity behaviors, general behaviors, mental well-being, and all that can also play a role. Food desert areas are associated with higher rates of obesity across geographical regions in general. Environments experiencing deprivation, lack of support, disorders, stress, or high crime have higher odds of obesity. The unavoidable marketing to promote obesogenic foods negatively impacts behaviors. There's the typical Western diet. What we call a typical Western diet are large meals high in refined grains, processed foods, red meat, unhealthy fats, and sugary drinks. Lack of safe places to exercise, lack of sleep is also a risk factor for obesity. Some of your patients, depending on where they live in their neighborhood, if it's not safe, they are not able to go for a walk. They don't have safe places to exercise. And all of this you have to take into consideration that will limit their ability to really have an exercise program, for example. Nutrition. How change in diet and physical activity, we know that a change in diet and physical activity are the first steps in guaranteeing one's success in weight management, right? However, it is important to consider environmental factors, like we said, age, culture, financial handicaps when recommending an obesity treatment. Decreased home-cooked meals contributes to obesity, but when we are going to recommend a diet plan, we have to take into consideration their financial situations, how they can cook simple home meals that would also help them to have a healthy lifestyle. Increased fast food, sugar, sweetened beverage, and snack intake, all these are negatively impact weight. Portion sizes of food are important. Industry marketing of unhealthy foods also promotes weight gain in these in these neighborhoods or these societies where they are really, that's what they have access to. Decrease access and cost of healthy foods. Usually your fruits and vegetables are what tend to cost more, and the fast food is quicker and more accessible, both financially and also you find them everywhere, unlike healthy foods where they tend to cost more and are not as accessible. Another way, this is to show you how decreased energy expenditure affect weight gain. So I found this graphic, if you want, that shows you ways you can prevent obesity. It has to do again with activities, increased sedentary activities such as TV or electronic use, social media use, that really affects our ability to be out and and being active. We tend to sit on the couch watching TV or being on our phones, so we don't put as much time in really being active. Reduction in energy expenditure of daily activities, like I said. So reduction also of physical activity in the workplace. We tend to be sitting at our desk all day long. If you can't, that's why now they are promoting those standing those desks where you can stand up to work. You don't have to be sitting, and you can do little exercise with those. They have foot exercise, foot pedals you can put under the desk to again promote movement. So we always have to be moving. Even if you're sitting at the desk, you can stand up, walk, and every hour, every 1 to 2 hours, take a 20-minute break to stand up and all that. And finally, we are going to go over some obesogenic medications. And because funny enough, some of the medications that we are prescribing are to help the patients can also be harmful in terms of their weight. So when seeing a patient, you should always look at their medical history. Switching medications or treating with alternative medications often helps with treating obesity. I'm gonna take a look at some of the most common ones that most people, for example, in a primary care setting, will be prescribing some diabetes therapies like insulin, sulfonylureas, I can never say that word, thiazolidinediones. There's also, and there are alternatives. Instead of prescribing those, we have a lot of options in diabetes, thankfully, and that are not weight promoting. So it's always good when someone has a disease of obesity to look at what other alternative to treat their diabetes. And we are going to see how the new molecules are treating diabetes while also helping with weight loss. Some steroid hormones, whether it's oral, inhaled, or the contraceptive, they tend to promote weight gain. Antihistamines, the first generations, antidepressants, antipsychotics, anticonvulsive. Some of the antidepressants, we can always use alternatives. Beta blockers, we prescribe beta blockers a lot in practice. And for example, metoprolol is weight promoting. We can always switch to a different beta blocker in the class to replace the metoprolol. This section here, we are going to address adipose tissue dysfunction. And we are going to see the role of adipose tissue in energy balance and the biological effects in obesity. There is more to the story than energy intake and expenditure. So we have to drop the calories notion. Now it's time to take a different approach. We cannot be saying weight loss is just a matter of calories in and calories out, what we are ingesting and how much physical activity we put in. Most people have been taught that losing weight is that simple math. And experts now are learning that this decade-old strategy is not working and it is inaccurate. And in fact, obesity is multifactorial. We already saw many other causes of obesity, but there is also a complex pathophysiology. So even careful calorie calculations don't always yield uniform results. How your body burns calories depends on several factors, including the type of food that you eat, your body's metabolism, and even the type of organism living in your gut. That's what we refer to as the gut microbiomes. You can eat the exact same number of calories as someone else, yet have very different outcomes when it comes to your weight. And I see that all the time, even amongst my friends. Some of them would be eating even more than the other, and they're like, they never gain weight. And I seem to just, and there's a joke that another woman might seem to just smell the food and they're gaining weight, right? So there was a good example. There's a show back in the that's been some years back. I don't remember. I didn't keep track of that show, but there's researchers studying the show The Biggest Loser, which helps contestants lose large amounts of weight through a stringent plan of diet and exercise, found that after weight loss, contestants' bodies would fight back to regain their weight. This is to explain to you how it's not that simple. Even after losing the weight, it is not as simple to keep the weight off. It is not as simple as just calculating calories in and calories out. There's also the resting metabolic rate for those contestants, which measures the number of calories the body uses. This is just to tell you there was more to the story. There was more to it, to the weight loss. And they used those contestants as a key point where they studied the weight, how they lost, how after they lost the weight, how much they were able to keep off. We'll go over that a little bit more later on with metabolic adaptation, when we are going to talk about metabolic adaptation. So what is the role of adipose tissue? What is the adipose tissue? So adipose tissue contains a vast variety of cell types like adipocytes. And during times of excess caloric intake, these cells adjust and they remodel in order to accommodate increased demand for triglyceride storage. So failure to do so may cause stress at the level of the individual adipocyte, leading to local inflammation and a significant impairment to accommodate this increased triglyceride load. And this is part of what we called metabolic syndrome, right? Metabolic syndrome, where you have high triglycerides, obesity usually, and some people can have diabetes and all that. So excess calorie intake induces cellular remodeling, accommodate demand for triglyceride storage. This is basically, in a nutshell, what the role of the adipose tissue is. Here, a busy slide talking about systemic effects of adipose tissue dysfunction. We can see how we see a normal adipose tissue, what it looks like, and a dysfunctional adipose tissue. With obesity, this adipose tissue becomes dysfunctional, and it has effects on different organs. At the level of the pancreas, we have insulin resistance. It can cause NASH, cardiovascular disease, dyslipidemia, inflammation, and these are our pro-inflammatory adipokines like leptin, and we're going to talk about that later. Anti-inflammatory adipokines like adiponectins, omentin, IL-10. So white adipose tissue responds to caloric excess through a healthy or unhealthy expansion. Healthy expansion through adipocyte hyperplasia protects against the metabolic complications of obesity. Unhealthy expansion through adipocyte hypertrophy promotes the obesity-associated metabolic complications that we just mentioned: insulin resistance, NASH, and all that, cardiovascular disease. What is adiposopathy? Again, I came back with that same graphic that we had. Central adiposity, we usually what we call central obesity, people who have an enlarged girth, abdominal girth. Central adiposity is a risk factor in establishing metabolic diseases. Regional distribution of fat in adipocyte morphology, like hypertrophy versus hyperplasia, contributes to obesity-associated metabolic abnormalities. Chronic low-grade inflammation leads to adipose tissue dysfunction, impairing adipogenesis and insulin sensitivity. This is the body fat distribution in obesity. We can see what visceral fat looks like in obesity, and subcutaneous fat also, and what the standard type is. And when you have obesity, you can see where you have the fat deposition. The pathology of obesity is closely linked with body fat distribution. Upper body visceral or ectopic fat accumulation in a much better predictor of comorbidities such as insulin resistance and dyslipidemia than total fat. Visceral fat is considered one of the ectopic fat depots, along with, if you want, hepatic, intramuscular, intramuscular, and pericardial fat. What is the role of energy balance in body weight? Here, we know that all energy comes from the food that we consume and drink. And in energy expenditure, basically, it's when energy consumed exceeds energy expenditure, 60 to 80% of the energy surplus is stored in fat. And this, again, will affect what? The body weight. Energy balance is defined as the state achieved when the energy intake equals energy expenditure. This concept may be used to demonstrate how body weight will change over time in response to those changes in energy intake and expenditure. When the body is in energy balance, body weight is stable. But there are many factors involved in this equation. Again, it's not just calories in and calories out. There are many other factors that will come into play when it comes to energy balance. Energy intake and expenditure are not the whole equation, but they are a significant part of it. The main players for regulating energy balance as a result of long-term energy stores are leptin and insulin. We are going to learn, I know you guys have heard those hormones over and over. We are going to dive deeper into the role of those hormones and how they work and how they play a role in obesity. Here again, we can go over the role of energy balance in body weight. We have the conventional model, how overeating leads to increased fat storage, if you want, carbohydrate insulin model here. So despite intensive research, the causes of the obesity epidemic remain incompletely understood, and conventional calorie restricted diets, they continue to lack long-term efficacy. If it was that simple, people could just stay on their calorie restricted diets, but how many people have tried those, right? And they fail. Why do they fail? We are going to learn why. Are these sustainable? In an article published in JAMA by Ludwig and Ebeling, they talk about the carbohydrate insulin model here. According to the carbohydrate insulin model of obesity, recent increases in the consumption of processed high glycemic load carbohydrates produce hormonal changes that promote calorie deposition in adipose tissue, exacerbate hunger, and lower energy expenditure. Beyond the type and amount of carbohydrate consumed, the carbohydrate insulin model provides a conceptual framework for understanding how many dietary and non-dietary exposures might alter hormones, also metabolism and adipocyte biology in ways that could predispose to obesity. Pending definitive studies, the principles of a low glycemic load diet offer a practical alternative to the conventional focus on dietary fat and calorie restriction. This is, again, a little blurb on the role of resting metabolic rate in energy balance. Humans, as we know, take energy through the intake of food, like mentioned before, and they expend energy through the resting metabolic rate. The thermic effect of food and physical activity. The resting metabolic rate is the energy expenditure required for maintaining normal body functions and homeostasis. The RMR is proportional to body mass, in particular fat-free mass, and the components of energy balance influence each other and serve to maintain a constant body mass. For example, when calorie intake is reduced, the body responds by both stimulating hunger and reducing the RMR so that less energy is expended. We will understand later on how this is important. Now we are going to see how energy intake is controlled, how peripheral and central signals are controlling, if you want, energy intake. And we will go over appetite regulation and all that. And we are finally going to visit how these hormones, what those hormones are and how they play a role in obesity. So appetite regulation. So why do people eat? The brain is the master regulator of food intake, right? And appetite is mainly regulated by three systems. We call the AGRP, the agouti-related protein neurons that are located in the hypothalamic arcuate nucleus, ARC, and stimulating food intake. There are neurons in lateral hypothalamus that are involved in positive feedback for increasing food consumption. And also there are neurons in the parabrachial nucleus that are potent suppressors, if you want, of food intake. So there are two areas of our brain. One controls is homeostatic eating, and the other one is hedonic eating. That's the hunger that's the part of our brain that's stimulated when we're hungry. When we feel full, this is the area that is stimulated, and this is the food reward center, and also what we call, if you want, that's where the cravings happen as well. We are going to dive into the different hormones, the role of the hormones. So the intestines produce what we call the incretin hormones. Two of the most popular incretin hormones are the GLP-1s and GIP, which are the molecules in the popular anti-obesity medications. So what is GIP? It's glucose-dependent insulinotropic polypeptide, and it stimulates insulin secretion, particularly following carbohydrate ingestion, right? GLP-1, I highlighted the GLP-1, which is one of the major hormones, since that's where we are going to act with our treatment. And it's called glucagon-like peptide 1, and acts as a hormone and a neurotransmitter, decreasing hunger, increasing satiety, and decreasing food reward. That's why a lot of people that are on GLP-1 receptor agonist, they tend to also, it helps with their cravings for sweets. Some have stopped drinking alcohol, some have stopped smoking. It completely cut their cravings for these other things. So these are being studied, but I have patients who tell me they cannot even drink alcohol at all. They just cannot stand it while they are on the GLP-1 receptor agonist. And a fun fact about the GLP-1s, it's a natural hormone that's in our system, actually. And when it's secreted after a meal, and usually it lasts only 2 minutes, we can see that how it doesn't stay around, meaning we don't have enough of the GLP-1 staying around to really help decrease our appetite or promote satiety. That's why the GLP-1 receptor agonist molecules on the market, they last longer. So the effect, it's usually a weekly injection, so the effect is around longer. There's also cholecystokinin, CCK, that can act as satiety signal to the brain. There's the oxymodulin, OXM, that acts to reduce appetite, both via a direct effect on the central nervous system, similar to GLP-1, and by inhibiting ghrelin release. We will learn what ghrelin does later on. The oxytocin infusion reduces food intake and increases energy expenditure in lean and obese individuals. We have the peptide YY, PYY. It regulates satiety, delays gastric emptying, food stays around stomach longer, we feel full longer, not hungry often. Next, there's the leptin, and the leptin is secreted by the adipose tissue. And what it is also a satiety hormone. Leptin acts on the hypothalamus to regulate the amount of body fat through control of appetite and energy expenditure. What is leptin? It is an amino acid hormone that's secreted by body fat, and it is in proportion to the amount of fat mass. It promotes, it promotes satiety and energy expenditure, and usually a deficiency of leptin signaling as a result of mutations of the leptin gene, for example, or its cognate receptor, causes hyperphagia and severe obesity. The people who lack that hormone are always hungry. And severe obesity in both humans and animals, they have seen that it leads to severe obesity in both humans and animals, which clearly demonstrates that normal body weight requires intact leptin regulation. Next, we are going over the hormones secreted by the pancreas, amylin and insulin. They affect glucose homeostasis and gastric motility, therefore promoting again satiety. Insulin is not only influences metabolism, but also promotes decreased energy intake. So that's why we will go over insulin in detail and the role of insulin in obesity. The stomach, finally, we are seeing the ghrelin, the role of ghrelin. That's the only hormone that the stomach produces, and it's known as an appetite stimulating hormone. So the contrary of the other hormones we've seen that are satiety hormones, promoting satiety, feeling full earlier, turning off the switch in our brain to tell us that we are hungry, it makes us feel full. Ghrelin, on the other hand, it's a hunger inducing hormone that promotes food intake. The role of insulin, we are seeing how adipose tissue dysfunction can lead to insulin resistance. That's why when seeing patients for obesity management, part of the workup, we also obtain a fasting insulin level to see if there's some type of insulin resistance. Insulin is secreted, like we know already, by pancreatic beta cells. Its levels are also positively correlated with body weight and adipose mass, and they provide a negative feedback signal to the central nervous system. Like leptin, high levels of insulin result in reduced food intake. Obesity is characterized by insulin resistance and hyperglycemia. That's why a lot of time we see patients with type 2 diabetes also have obesity. According to some studies, increased insulin secretion contributes to obesity pathogenesis by stimulating the adipocyte uptake of fatty acids and glucose and the caloric storage in form of fat, while concomitantly inhibiting lipolysis. Again, these are the biological effects of insulin. Insulin is the primary hormone involved in energy storage and signals the brain regarding energy needs and stores in the body. In the brain, insulin turns off hunger and increases metabolism. So if we have insulin resistance, we lack that faculty, if you want. Insulin resistance means the body needs, that's in a nutshell, this picture here, what it's telling us. Insulin resistance means the body needs to produce even more insulin to reduce hunger. These increased levels also increase fat deposition in adipose tissue. Sleep, stress, and obesity. Sleep and stress have also a major role in obesity, and this is why it's important in the history taking when addressing obesity weight loss management with a patient. You have to take their not only their psychosocial history, but their sleep history, their sleep pattern. How many hours do they sleep? It's required 7 to 8 hours, because a lack of sleep will also promote weight gain. And we are going to see how this plays the physiology behind all that. So there are the physiologic effects of stress. Stress brings a response in the hypothalamic and pituitary axis, and that's short HPA. And it's hypothalamus, pituitary, and adrenal glands. This is where the fight or flight response starts, like we've learned in PA school, and it has profound metabolic effects. It influences how our brain processes rewards. Finally, hormones that affect hunger fluctuate under stress. All those hormones that we've just learned about, leptin, ghrelin, or GLP-1, all these hormones, they fluctuate under stress. Levels of leptin, ghrelin, and neuropeptide Y can change and contribute to more hunger and therefore more fat storage. Pathway from stress to obesity. Here we are seeing how stress and obesity are more closely intertwined than we previously thought. That's because stress can affect several systems involved in weight control. There are multiple pathways. The connection between stress and obesity takes many paths. Stress affects our capacity to think, the cognition. Under stress, we make poor decisions. We can't regulate our own behaviors as well. Impulses turn into actions, but those actions reflect choices that are not necessarily, if you want, healthy choices. They're quite different from choices we would make in a state of less stress. Stress can also have a more direct effect on behaviors that contribute to obesity. Under stress, we will eat more of the foods that are high in calories, sugar, and fat. We might have difficulty sleeping or finding time for physical activity. Still with the role of stress in obesity, again, another view of how cognition, behavior, biochemistry, but let's dig into the details here. In terms of cognition, stress can mess with your mind, specifically thinking, planning, and organizing, as well as the ability to focus and manage your emotions. There are two major reasons that explain how stress causes obesity. The major the major reasons here are behavior and physiology. The behaviors that stress influences what we eat, how much we move, how well we sleep. And these behaviors all have their own feedback loops too. Mostly individuals who are stressed tend to eat even when they are not hungry, and usually they make unhealthy choices. This is referred to as emotional eating. Physiologically speaking, it basically, quote unquote, jacks up hormones that leave us hungry, boost cravings for sugar and fat, mess with your microbiome, and increase fat storage. A limited number of factors result in obesity, the major one being cortisol and cortisol-induced insulin. Continuous high levels of cortisol play a significant role in obesity development. Normally, cortisol, like we know, facilitates the management of stress, like we've learned in endocrinology. Therefore, when stress levels go up, cortisol levels equally increase. Biochemistry, stress may also impact blood chemicals like leptin, ghrelin, and neuropeptide Y, and we know how important they are in appetite regulation, which affect hunger then and fat storage. Weight stigma, according to the researchers, obesity leads to weight stigma, which then creates more stress, and on we go on that vicious cycle. Those with higher stress levels who are sleep deprived will be more likely to gain weight and become obese. Role of sleep again in obesity, sleep disturbance. It's not only lack of sleep, but if we have sleep disorders, this could increase the risk of developing obesity. It leads to increased fatigue, decreased physical activity. It also affects some of the hormones, decreased leptin, increased ghrelin, which will lead to increased food intake, and those food usually are low in fibers, but high in fat and carbohydrates, and all of that will lead to, again, the disease of obesity. This picture here obtained from Chaput and al. They published a model of changes in appetite hormones, hunger, and energy intake in response to insufficient sleep. This is to show how these hormones also play a role in response to are affected by insufficient sleep. The physiological response to weight loss that encourages weight regain, the decreased metabolic rate increases hunger hormones and decreases fullness hormones. It is particularly the hunger hormone ghrelin, right here, which triggers appetite increase, signals the brain to drive body weight or body fat mass back to where it was when you started. So the peripheral appetite stimulating hormone, also ghrelin, and the satiety hormones leptin and peptide YY feed back to the brain to influence appetite and hunger. When sleep is restricted, but diet is controlled for the energy balance needed for a typical day with adequate sleep, the appetite stimulating hormone ghrelin is increased and the satiety hormone leptin is decreased, resulting in increased hunger levels. By contrast, ghrelin is decreased and leptin and PYY are increased under what we call ad libitum diet during restricted sleep, reducing hunger levels. So changes in appetite hormones during ad libitum diets are probably due to increased energy intake during sleep restriction. There is a relationship between inadequate sleep duration and calorie intake. Let's say we have brief sleep, so not sleep disorders, not lack of sleep, but the person sleeps, but it's brief. It's not enough hours. When we don't get enough sleep, our full 7 to 8 hours, insufficient sleep, and this and the circadian misalignment are important metabolic stressors that are associated with weight gain and obesity, and all of these we can see can lead to overweight or obesity. So sleep restriction, it increases the drive to eat, and excess food intake resulting from not sleeping enough is more related to cognitive control and reward mechanisms than to appetite hormones. So circadian misalignment reduces 24-hour energy expenditure by about 3%, they say, and alters the levels of appetite hormones, promotes unhealthier food choices than conditions of adequate sleep. We have seen the causes of obesity, the role of the hormones in appetite regulation, genetics, epigenetics, role of sleep and obesity. After all that, if all goes well, let's say, and there's no dysregulation and the patient loses weight, or you start your patient on a treatment or weight loss management or a physical activity program, a diet, whatever it is, however way you address their weight problem or their obesity disease, how do they keep that weight off? How our body responds to that weight loss. After losing the weight, then what? What happens? And that's what we call metabolic adaptation. So what is metabolic adaptation? So people can have different metabolism, even I've mentioned before, among individuals at the same age, same sex, same weight, same body composition, eating the same food, same type of food, but their response would be different. We will discuss the relationship between energy intake, energy expenditure, and metabolic adaptation. We have learned how energy intake and energy expenditure play a role in weight gain, but how does that intertwine with metabolic adaptation, influence metabolic adaptation? We'll also explore how these factors affect weight management, especially in individuals who struggle with their weight. What is the metabolic adaptation? Why is it an important concept to understand? So it is the body's physiological response to weight loss due to reduced calorie intake that can ultimately promote weight regain. And that is one of the major problems of patients suffering from obesity. And by slowing their metabolism while altering appetite regulating hormones, and thus can be a barrier to maintaining long-term weight management. This is where the new medications will play a role, the maintenance phase of the long-term weight management, losing the weight and keeping it off. The body reacts by slowing metabolism and altering appetite regulating hormones. So it is very important. I'm emphasizing on this because that's what will help you understand why obesity is a disease, why it needs to be addressed by a medical professional, why the patients need guidance, why they need help, and how they cannot just do it on their own. They cannot just eat less and move more. That's not enough because our body reacts in response to weight loss. Our body has a way of compensating for that weight loss. So to help your patients with overweight or obesity managing their weight, metabolic adaptation is a fascinating topic to discuss, and it's so important to understand in the context of weight loss and weight maintenance for our patients with obesity. So metabolic adaptation is the body's biological drive to regain the body mass that was lost. They feel like they think your body feels like you're starving, and they feel like they need to retain calories. They need to put you back where you are. They are used to that certain weight. Also, metabolic adaptation is the body's physiological response to weight loss due to reduced calorie intake that can ultimately promote weight regain by, like we said, slowing the metabolism and all that. And this is a huge barrier in maintaining long-term weight management. And this is what is the major driver in explaining why most patients are not successful with weight loss programs with those low-calorie diets, because that's not enough. They are fighting their bodies after that weight loss, and we are going to see why. This is the metabolic adaptation. There's a tug of war, we say, of weight management. So the physiology of weight loss creates a tug of war in the brain and the body. That busy slide here, to sum it up, I think that most of my patients who try to get control of their weight, they have experienced that. They would tell me they've tried many diet plans, they lost the weight, but they regained the weight. And sometimes they are at a higher weight than they started off. So despite changes in their lifestyle, physical activity, the weight is very difficult to keep off. And given their best efforts, the weight is still not staying off, and they are discouraged. They are very miserable. It's like a metaphorical tug of war between your lifestyle modification that includes decreased calorie intake and increased activity. Anyone who's tried to lose weight more than one or twice or two times in their lifetime has probably experienced this struggle. And we know that it's very important to have a supportive environment and not to do it alone. And that's where your role, that's where you come into play. And that's why it's important to understand all the pathophysiological changes that occurs in obesity to better address and help your patient, to better address the disease and help your patients. And why does this happen? There are two hypotheses. There's a thrifty gene hypothesis that several thousand years ago, environmental pressures and natural selection would favor those who could survive long periods of famine when food was scarce. There's another one, that's the hypothalamic feeding center, that there's an axis between all our organs and central nervous system that would tightly control food intake in the long term. So the system receives afferent signals ranging from hormones to the gut or adipose tissue that would establish a set point of energy reserve, primarily in the form of adipose tissue and organ and glycogen storage threshold. So basically, our body learned to adapt. They have a set point, just like when you have a fever. If, let's say, your body temperature, let's say you go out in the heat, it's like in Florida here. I'm in Florida, 105 degrees out. Our body is not gonna burn up. We adapt our body. There's a set point, just like you have the set point for temperature in your brain. It's the same thing that happens in that setting. You would adapt. As the body loses weight, metabolic adaptation occurs by affecting hormonal changes. Again, the hunger hormone increases and the satiety hormones decrease. And I highlighted the GLP-1, which is one of the satiety hormones. Your body is trying to compensate. You will feel more hungry the less you eat, and the satiety hormones will be lower. So now, simply put, when your outs are greater than your ins, that's when you start to lose weight at this simplified level, right? But as you start to lose weight from eating less calories, your body has this response that enables it to adapt to this lower calorie intake by reducing your energy expenditure, increasing your hunger and appetite, and decreasing your satiety. And these are how those hormones come into play. And this is caused by changes in appetite hormones and the slower metabolism. As a result, you may start to eat more, regain weight. Really, what this means is that when your patient with obesity starts to lose weight, their body tries, like I've mentioned before, adjusts itself. The set point observation. Here I put a picture of how the different roles of GLP-1, how it affects, how it is in the stomach. It decreases gastric emptying and GI motility. That's why patients who are on these molecules, they feel nauseous, they feel full, they can have vomiting because food stays around longer. It takes longer to digest the food. They have a slower motility. And in the brain also, it works in the brain. It makes you not feel hungry, turns that hunger switch in your brain, and reduces food intake and water intake. And a stomach that is empty, it shows you what happens. These hormones to increase appetite, they go up. When the stomach is full, the switch is turned off. all those hormones to decrease, the ghrelin goes down and all that. Okay, I'm full now, I don't need more food, so the hunger hormone like the ghrelin is reduced. It has been shown in many studies and observations of weight loss, but there's also a change in energy intake side of the equation that has to do with the appetite regulation and hormone changes like we see here. So the action of GLP-1 is impaired in people with obesity, even in those with normal glucose tolerance, resulting in increased gastric emptying and decreased satiety signaling. These are long-term, again, in the setting of long-term weight management challenges. This was a study that was published by Wang and al. And the purpose of the study was to assess if there were differences in the brain dopamine receptors in severely obese individuals. And the dopamine system was assessed with a radio tracer that binds to dopamine D2 receptors. It's the raclopride that we see here in the picture with PET and positron emission tomography. So they found that striatal dopamine D2 receptor availability was significantly lower in obese individuals than in the control group. And in the obese individuals, the BMI correlated negatively with the measures of D2 receptors. The individuals with the lowest D2 values had the largest BMI. That's in a nutshell what this slide is about, really. And after weight loss, metabolic adaptation leads to decreased resting metabolic rate and lowering energy expenditure. We have some percentages here. Metabolic adaptation, after all, it's a universal phenomenon where energy expenditure is part of metabolic, and we know that energy expenditure is part of metabolic adaptation. To better understand what that means, let's take a step back and talk about energy balance. So what is energy balance? Energy is just another word for calories. So energy balance means there's a balanced state where calorie intake is equal to calorie expenditure or energy expenditure. And since it's equal, you maintain a certain weight. Calorie intake and calorie expenditure are two factors that really help determine energy balance. And that's explaining energy balance at a very simplified level. Because while calorie intake might be easier for some to understand, energy expenditure, that's a really whole different story. It is really hard to know how many calories someone is actually expending and burning. So when your calorie intake increases over your calorie expenditure, you start to gain weight and vice versa. So in other words, after weight loss, metabolic adaptation may lead to a decrease in resting metabolic rate, or your RR, and lower energy expenditure, which can also unfortunately lead to weight gain. In the real world, what this means is that while substantial weight loss is possible, people can lose 20, 25, 30 pounds by following different treatment regimens. Sustained long-term weight maintenance can be more challenging. And I think that's where the challenge is. And that's probably why these new molecules, the GLP-1 receptor agonists, are very popular. This is before we conclude with the metabolic adaptation, a constellation of factors associated with long-term weight loss maintenance in the general population of people with obesity. Again, maintaining weight loss is difficult because of all these other factors that are influencing weight maintenance. And I think it's really, what it boils down to is to really heal your patient's journey, healing their pathway, learning about other multiple causes that lead to their gaining weight or having difficulty taking it off. You know, whether it's environmental, psychosocial, behavioral, a lot of things we talked about from a biological point of view, but we also have to understand the community they live in, the type of neighborhood they live in, their culture. We have to take all of that into consideration, where they work, where they play, and all the barriers that they can encounter. Sometimes it's some personality traits. Sometimes it's just they lack self-confidence about losing weight without help. They're not satisfied with the results. So we really have to take into consideration our individual patients and tailor management and the care to their particular situation. Each of your patients are unique. There's no one size fits all. it will be on a case-by-case basis, depending on their situation, that you are going to tailor their management. So it is good also to learn about different management. If you want different ways you can manage obesity, there's no one size fits all. These are, in conclusion, what have we learned in a nutshell is that obesity is a chronic, again, I'm going to emphasize chronic, progressive. It's not stagnant, it's gonna get worse, multifactorial. There's a lot of things that affect obesity, and it is a disease. It's not willpower, it's not a matter of lifestyle. It is a disease, and it is attributed to genetics, hormones, medications, several environmental factors like we learned tonight. Sometimes it's called a relapsing disease, with recurrence needing long-term treatment and vigilance, just like your other chronic diseases like hypertension, diabetes. And it is also important to set realistic expectations when addressing obesity with patients. An increase in, we have learned about adipose tissue and the dysfunction and how it affects and the role in obesity. So an increase in body fat promotes adipose tissue dysfunction and hormone changes that result in adverse health and metabolic consequences, such as fatty liver, insulin resistance, cardiovascular disease, dyslipidemia, and inflammation. We have also learned how sleep and stress play key roles in obesity management. My key takeaways here, indeed, facing metabolic adaptation that you didn't have before weight loss, you must compensate for that. So obesity, again, it's a growing epidemic in the United States, which is why it's important to learn about it and to address it, especially in the states where it's prevalent. It is a chronic disease. Again, I'm emphasizing on that. We learn about metabolic adaptation, how it is a universal phenomenon that counteract patients' weight loss efforts, which interferes with their success at keeping the weight off. And obesity is a disease that often requires comprehensive. It's not just increased physical activity, control your calorie intake, but it requires comprehensive long-term. I'm emphasizing on long-term treatment plans, because after losing the weight, you're not done. You have to be able to fight those compensation mechanisms that happens with metabolic adaptation for long-term treatment plans, given that what we've learned about the physiology, the chronicity, and biological changes that contribute to it. And remember, understanding the complexities behind obesity is treating it. The fact that we learned tonight how the pathophysiology of that disease is already one step in treating obesity. Thank you for sticking with me for that long lecture. I hope you've learned I hope it was helpful in understanding the pathophysiology and how the obesity is a disease. Thank you.